Okay, I'm glad everyone had a good lunch. My goal is to record these and put these on YouTube tonight, and I'll email y'all like last time. Watch them again if you want or not. That's up to you. But I did choose to go ahead and, so I started creating my own. I'm like, it's really hard to put all of neurology in 4 hours. So I ended up deciding to use their PowerPoint as a template, but I deleted some of the hot garbage that was in there. But I had to leave some of the garbage because if you haven't caught on, your tests and the bank they use in School of EMS comes straight from this book. So when you buy this book as instructors, they send you this big test bank, and they're pulled from this book. So it's not always what I think is important, but it's what's going to be on your exam that kind of, unfortunately, is a metric of our success. So with all that to be said, I went through there and I added a lot of pictures and some explanations. So today is your chance to stop me, ask me questions, clarifying points. It is a rather long day. We will be taking breaks every 50 minutes or so. So I would imagine we'd be out here by 4 though, since we've already done the throw, okay? Any questions on that? Okay. Here's a QR code that'll take you to it if you want it or not. That's up to you. That'll work. All right. So, any questions? Everybody good? Fired up? All right. Let's start with some epidemiology, but I really don't care. So we're going to skip that because I want to talk about the central nervous system. So the central nervous system is comprised of things that are located centrally, not just the brain, but the spinal cord. Students miss that because they think the spinal cord is peripheral of the brain, but think central nervous system, central stuff, the stuff in the middle, okay? So it is the brain and the spinal cord, okay? And the idea of the central nervous system is thought, perception, feeling, and autonomic body functions. What does an autonomic body function sound like to you, Cooper?
Automatic?
Yeah, automatic. Things that we're not really thinking about, like breathing and staying alive, right? Those things that are not underneath our conscious control, right? Our heart rate, blood pressure, all that. We don't mess with that. And then peripheral nervous system, so this is the nerves in your fingers that are located peripherally that are going back up into your central nervous system. So this is transmitting information from your periphery back to your central nervous system. And what I see a lot is a lot of times they won't ask you really difficult anatomy questions. They'll just straight up ask you, they'll just ask you a question as it relates to the peripheral nervous system. Oh, it provides feedback. Or they'll say, is the spinal cord part of the peripheral nervous system or central nervous system, right? So they're going to ask you stuff like that in my observation, okay? Now, I think this is confusing, but I have a point on here that I need to make. So I tend to not like the charts they use in your book, but there is a section down here that is going to be on your test. So earlier this week, me and Jeff went through y'all's exam, and I'm going to tell you some of the things that are coming up that you should especially know. This happens to be one of them. So as you know, the autonomic nervous system, as in the systems we don't think about, breathing, blood pressure, heart rate, all that stuff, it's divided in two. We have our sympathetic nervous system and our parasympathetic nervous system. So when you think sympathetic nervous system, we've heard fight or flight, right? The neurology professor I had in medical school, he would always say, if you're going to fight a bear, what do you want? Okay, you want a high heart rate? You want a lot of blood flow? You want your eyes to be wide open so you can take in lots of light? You don't necessarily need to be digesting your chilies. You don't necessarily need an erection, right? You don't need those things to fight a bear, okay? So you do have to know these divisions. They ask this a lot because it ties into pathophysiology and it ties into pharmacology. Now, what's the question, Hunter? This is the question. The parasympathetic nervous system, which is rest or digest, or they like to use the word feed or breed. Why do you think they're using the word breed? It's because the parasympathetic nervous system causes you to point, guys, right? This also means you get an erection. So the parasympathetic nervous system is in charge for erection. Now let me tell you this. When you completely transect the spinal cord and you get a medical word for an erection, a priapism, have y'all heard of that? Yes. Spinal trauma, priapism. Why is that? It's because you turned off the sympathetic nervous system and the parasympathetic nervous system kicked up. It also kicked up an erection with it. So that's why that happens, okay? So that's the whole feed or breed. So one way to remember this is P, parasympathetic, point, like an erection. And then S for sympathetic is shoot, and this is ejaculation, okay? And you may think I'm weird that I'm telling you this, but in pharmacology, this becomes pretty important. They'll especially in medical school, which I know we're not medical school, but like people that take antipsychotics or antidepressants, they have a hard time with ejaculation, right? So that's why. But I'm just pointing that out. Now, here's what's going to be on your exam that this is important to know, okay? So, parasympathetic nervous system, the main mediator of this is acetylcholine. This is word for word on your exam. What is the main neurotransmitter of the parasympathetic nervous system? It's acetylcholine. It is on your exam. And I actually can't even hate on whoever asked that question, because there is a specific drug that we give that blocks the parasympathetic nervous system. What do you think it is, Dylan? We talked about it this morning with RSI. Atropine. Guys, atropine blocks acetylcholine, okay? So the idea is when you do give atropine, it blocks the effects of the parasympathetic nervous system, because what we're actually blocking is acetylcholine. So if you don't have as much acetylcholine, you don't have as much parasympathetic nervous system. If you don't have as much parasympathetic nervous system, you don't have as much salivation, lacrimation, urination, defecation, gastroemesis, right? Sludge, right? So that is why this becomes important. This isn't even them being fancy. You have to know parasympathetic nervous system equals acetylcholine. They want you to know that. What happens when we get too much acetylcholine? Sludge, salivation, lacrimation, urination, defecation, gastroemesis. How do we fight that? What's the antidote? It's atropine. We give atropine because atropine blocks acetylcholine receptors. Okay? Everyone good on that? Now, can anyone name off a sympathetic drug? There's tons of them.
Epi.
Epi. What's the generic name, or what's the trade name for epi? It's fine, it's fine. Adrenaline, right? It's adrenaline. That's the trade name, is adrenaline. Okay? So everybody good on these divisions? I know we spent a while on this, but I just want you to know that they are going to grill you on this. This isn't fanciness. This is fair game. All right? All right. Moving forward. So, we do have our little brain today, which is awesome. Shout out Amazon. And they, this is just barely scratching the surface of the brain, but they actually want you to know these distinctions. They'll straight up say, your patient's having visual disturbances. Where's the likely deficit? It's the occipital lobe, right? Or, the frontal lobe contains voluntary motion, right? So they could say, they'll give you a stroke type question and they'll just ask a generality of where's the lesion. When I say the word lesion today, it means where's the injury, okay? They'll say where's the lesion, and they'll just want you to name these off like that, okay? It goes much, much deeper than this. But I want to point out a few things. This right here is called the central gyrus, right? It's located right here on this brain, okay? And when you meet someone, we call, like a female, we call them Miss, okay? And what I want you to remember, it goes motor movement, and then it goes all into sensory, touch, vision. That's all our sensations, okay? So if you can remember, the front is motor, the back is sensation, then that's a good start, okay? That could get you some points on an exam. Everyone good at that? And let's just talk about some general anatomy locations. The frontal lobe, the front of the brain. The parietal lobe, it's going to be the sides of the brain, like right here. The occipital lobe is the back of the head. And the temporal lobe, that's what I was talking about earlier, right? This makes sense. Where our temporal bone is, right? This is where time goes, okay? Now, what is this area right here is called the cerebrum. Say it with me. Cerebrum. Compared to the cerebellum, which it's not green on a real patient, but they painted it green on this model. Okay? Students get real hung up and they confuse the two. So think cerebrum, gray matter, the majority of your brain. We can do emotion, movement, touch, sensation, right? That's the cerebrum. Now, the cerebellum, this bottom part, that is for, which is the next slide. We talk about the GPS of the brain. So don't confuse the two. Very easy to confuse them. So again, going back, these are fair game on your exam in the National Registry. And this is just barely touching neurology, right? But these are fair game, and it might seem pedantic, low yield. I wouldn't say they're low yield. They're really not. Okay, everybody good with that? So this is just general anatomy for now. Now, before we go into the cerebellum, let's talk about nerves, because this becomes very important. So nerves are the smallest, and neurons are the smallest units of the nervous system. And so these are cells. These are individual cells. And just like cells, we have a nucleus. So what happens is this is the bulk of the nerve. And these dendrites are like little fingers, and they go out and receive messages by finding chemical mediators, glutamate, glutamine, dopamine, epinephrine. So they're out there just feeling around looking for stuff. And then what happens is you get a signal in, and it is carried down this axon, which is this part. And it's insulated with Schwann cells or oligodendrocytes. We'll talk about the difference between them at the end. But just know that there's myelin. So everyone can imagine speaker wire, right? You know what I'm saying? I bet you, definitely you, and maybe you, all had a big bass kicker in your in the high school in the back of the truck, right? Am I wrong? Was I wrong? Cooper, I was wrong, wasn't I? He's looking at me like I'm crazy. But you know what I'm talking about. The kids that drive around in the high school parking lot with the bass kicker. So speaker wire is very relatable. And why is it insulated? It's to keep the message coming from your radio down to that speaker in one piece. And there's pathology where the myelin, right, the outside of the speaker wire gets jacked up, right? Multiple sclerosis, right? That's a big one. Guillain-Barré syndrome, okay? ALS. So all of these, there's disorders with that. So I want you to know that there is this fat that goes around the axon that keeps the message in one piece all the way down to its target, okay? Moving forward. Let's talk about what happens at the synapse, because I'm sure you've heard this a lot. And this whole synapse thing, it's really not complicated at the level we got to know it, but it pops up a lot because this is the hallmark of pharmacology, especially neuropharmacology, okay? So, this message is coming down, okay? There's a message that came from the neuron, or from the end of it, and it's coming down this long highway, and it finally gets to the end, okay? This is the end of a single nerve cell. And what happens is, this action potential, it can be electricity, just like in a heart, action potential. And what causes the heart to contract? It's movement of ions. In this case, in the nerve, it happens to be calcium, okay? So what happens is, there's enough electricity that comes down that this calcium will start popping off. And it'll literally go pop, 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 pop. And as it starts popping, it depolarizes. And as it depolarizes, it shoots out these little bubbles, kind of like blowing bubbles, of neurotransmitters inside. In this case, let's just call it dopamine, right? So in this case, it's pooping out some dopamine out the end of it. And this space right here, they actually want you to know, is called the synapse, right? So this area, if you ever hear like synaptic cleft or the synapse, it's the space between one nerve to a target. Everybody good at that? Okay? Now, when we release our dopamine, or whatever the transmitter is, acetylcholine, epinephrine, pick your poison, it has to bind to a receptor. So it'll bind to a receptor, and when it binds to the receptor on the target cell, that cell will do its job, right? In this case, it might be euphoria or memory or whatever it is, okay, that dopamine would do. So why am I telling you this? Because every single one of those steps can be interrupted by medicine. We either make it work better, or we turn it off, or we slow it down. So we can delay the depolarization of this. We can delay these vesicles getting shot out. We can block this receptor. We can make them stay in the synapse longer, right? So have you ever heard of a selective serotonin reuptake inhibitor? Antidepressants, right? Prozac, okay? What happens is, these are floating around out here, and if we are selectively delaying the reuptake of them, we're going to tell serotonin, just stay here. We're not going to allow you to go back home. So they end up staying floating in the synapse, binding to receptors longer. So that's just one example of pharmacology. But this is the hallmark of pharmacology. If you understand this, you got pharmacology. This is it. This is very foundational, and that's why I'm hitting it. So, any questions on nerves and how these work? Okay. The beginning of this lecture moves slow because we're laying a foundation. Okay. All right. Moving forward. Now, there's some fancy words that they like to use in paramedic school. So you know when we're babies, we have like these different layers that form, okay? One of them happens to be called the diencephalon, okay? It's the word that they like to use. But the diencephalon is like an umbrella, and up underneath that term, there's a few things. The thalamus, the hypothalamus, and the epithalamus. So what does that mean? When they say diencephalon on your exam, they're talking about the hypothalamus, the thalamus, or the epithalamus. So they love to use this word in paramedic school for whatever reason. To me, it's kind of baby talk, right? It's like, I don't know why neurologists prefer to use that, but instead of just calling it what it is. But I'm just letting you know that, don't be scared by that word. They mean hypothalamus 9 times out of 10, okay? So, let's just talk about the diencephalon. So this is your conscious versus like unconscious management of information, right? And that's what they're saying. And the idea of the diencephalon is to filter out unneeded information. Is it hot? Is it cold? Just random sensory information. Where are we at? What are people doing? What's the movement in the background? So it's filtering out information, but that's not super important. When you think hypothalamus, you should be thinking temperature regulation, right? So when we have a fever, there's upregulation there. So you end up with fever. It's from the hypothalamus. Or hypothalamus also produces a ton of endocrine hormones. It all starts there and it goes down to your pituitary gland, which we're going to talk about in a minute. But so when you think diencephalon, think regulation of the body. You should also be thinking endocrinology, right? Antidiuretic hormone, growth hormone, luteinizing hormone, FSH. All that starts there and it moves down to the pituitary gland. Okay. So everyone go to diencephalon. Yeah. I can show you this on this brain that I'm holding. It's up here. It's this thing. Okay. It's this top piece. Everybody good with that? All right. Now, the brainstem itself, right? I'll just pull it out of this guy. The brainstem is very important, right? So the brainstem, it's what, without a brainstem, we die. And there's pathologies involving the brainstem, and we're going to talk a lot about them because as paramedics, we have to be aware of how people die. So the main thing that they want you to know is that the midbrain, okay, let me just take a step back. It goes midbrain, pons, medulla. Okay, so the midbrain is up in the middle of the brain, and that's this top part right here. And then the pons is this little section here, and then it goes down into the medulla, this bottom part. Okay, and as you can see, that's what they're showing you here. And what they want you to know about brainstem is it's the functions of life: breathing, heart rate. Those are probably the biggest one, but also level of consciousness. And the reason they care so much about level of consciousness, have you ever heard of decorticate versus decerebrate posturing? Yeah. Why is that important? Because at one point, you have a lesion above the midbrain. At another point, you have a lesion below the midbrain. And when you go below the midbrain, it's even worse. Because what did I just tell you? The midbrain is the single most important part of staying alive. Okay? You ever hear those people that shoot themselves in the temple and they don't die? Mm-hmm. It's because they didn't get their brainstem. Right? They end up dying eventually because it herniates on their brainstem. But those are the patients that you have. I mean, I'm not telling you how to do it, but if you don't hit your brainstem, you may not die. And we run that quite often where people mess that up. They don't hit their brainstem, okay? So, that, especially temporal shots where people shoot themselves like in the forehead. So, now this thing looks a little bit scary, but I want to talk about it. You're not going to be expected to label these. So I wouldn't even write this down. I just want to make a point of what we're looking at. It's important to know that if I were to take Corbin's brain out of his head, freshly after, taking it out when he was recently alive, no formaldehyde, right? No preservatives. The brain itself would collapse on itself. It is that soft. It is softer than soft. It could not support its own weight. You could not hold an unpreserved brain in your hand. It would collapse. So when you think brain, you need to realize it's very soft. And the reason I'm saying this is we see stuff like this. This brain has been preserved. It's been dipped in formaldehyde. Okay, when we embalm people or we do cadaver labs, we put formaldehyde all over the body. It draws out some of the moisture, but it preserves it. Okay, so that's very important when we think about trauma. Is I think a lot of times people actually think the brain is like hard. It's not. It's very, very, very soft. And in medical school, we had some cadavers and we took this guy's brain out, and I was surprised by how rigid it was. This is where I learned this from the professor. But it's very weird taking someone's brain out when you think, wow, this is their emotion, this is their thought, this is every bit of their memory, and you're holding it in your hand. Very strange. And then we continue to dissect it and cut it up. That was even weird. Just a weird feeling, but part of medicine, right? So I'm just pointing out the brain is very, very soft. This is a very well-preserved brain, right? It's an anatomy model, this one. So this up here, cerebrum, gray matter. This guy down here, cerebellum. Okay, there is a difference between the two, and I want you to know that. Now, the midbrain is up in the middle, up in the top. It's mid, right? It's in the middle of the matter. And then it goes, so that is part of the brainstem. And then we go down into the pons. So let's think about something. Have you ever heard if someone has a stroke, on the right side of the brain, they have left-sided arm weakness? Y'all heard that, right? Yeah. Why? Well, it's because of decusation. Yes, you're right. But what happens is the right side of the brain, The nerves over here cross. Where do they cross? They cross in the pons. So if you wonder why this is sticking out like that, it's because they are literally making an X pattern right there in the pons. Okay? So that is the reason this is happening. It is crossing right here in the brainstem. So that is why the right side of the brain is controlling the left side of the body. That is why when you have a right-sided stroke, you have left-sided arm weakness, etc., etc. Okay? So as you go down from the pons, you get into the medulla. Have y'all seen Waterboy? The medulla oblongata, right? With the alligator with all them teeth. Yeah, this is where respiratory control is made, okay? Chain stokes, biots, apneustic respirations, they come from here when you start pushing on it. A general principle you have to know today is when you start pushing on the brain, shit stops working, okay? It doesn't do what it's supposed to do. Very important when we start talking about herniations. But when you start pushing on the brain, or not giving it its oxygen, or not giving it its glucose, it stops working, or it doesn't work the way it was designed. So that's a general principle, okay? Now, lastly, before we move on to this, remember I was talking about all those 12 cranial nerves that are super annoying? They come off of the brainstem, okay? So these nerves do different things, whether it's vision, or smell, or hearing, or facial expression, or taste, or raising your traps, or your tongue, or whatever it is, gagging. They all have different jobs, and we're going to talk about them. But I want you to be generally aware that, like, for example, like this one will allow your right eye to look right? Cranial nerve 7, this is facial expressions, okay? Cranial nerve 10 right here, see how big it is? That's for swallowing, that's for vomiting, that's parasympathetic, right? Cranial nerve 12, that's your tongue. So I'm just putting out some generalities that you need to be aware of general anatomy. Everyone good at that? Mm-hmm. All right, let's keep moving. Now, they get real hung up on the limbic system. They want you to know, which this isn't, I'm not even going to go into that. This is like a fairly broad statement, but the limbic system does generate rage and anger. So how are they going to ask this? They're going to tell you some patient has rage and anger. Where is the pathology located? It's the limbic system. Okay, or they might just straight up ask you, where does rage and anger come from? It's the limbic system. Specifically, it's the amygdala. But that's fine. But I'm just letting you know, they will ask you that. Limbic system, rage and anger, okay? The hypothalamus, this controls pleasure, thirst, hunger. It also controls temperature. So have y'all ever heard of, like, when you get fever, the hypothalamus will increase your body temperature, which we don't have to know in paramedic school, but there's different lobes of the hypothalamus, and so like in medical school, like all the one of these weird sayings is, you call it a hot ass, right? Because posterior hypothalamus also raises. That's the lesion. That's where the lesion will be to raise temperature. So just kind of a generality. And this is what I was talking about earlier too, motor, sensory, which I'm kind of jumping around. I need to not do that. But anyways, moving forward. Prefrontal cortex regulates emotion. Has anyone ever heard of the procedure called a lobectomy? They stopped doing them in the 60s, yeah. Right? So what they used to do was they used to take a tool and go up through the ethmoid sinus, through the nose, and literally just start taking out chunks of the frontal lobe. And what they found is when they did that to schizophrenic patients, they started behaving. And why is that? Because when you start removing, or psychotic patients too, when you start removing this, they lose a lot of emotion. So they had flat affect. They started having no emotion, right? They were kind of zombified, and you were destroying people. They didn't know at the time, but you were destroying people. So just as a generality, you do need to know prefrontal cortex. This is regulation of emotion, okay? All right. Let's move back over here. So, and again, these three, they sound nitpicky. They're not. They're fair game. They will ask you these types of things, okay? Now, remember when I was talking about the thalamus, hypothalamus, right? And they go down to the pituitary gland. To me, the pituitary gland looks like a set of small testicles, right? They're like on a little stalk, and they go down here. And if I were to pass this guy around, right here in the cella turcica, that's how small it is. So I'm going to pass this around. The one labeled 43 is where the pituitary gland would sit. Very, very small gland, but this regulates almost all endocrinology. All of endocrinology comes down to a pea-sized gland that sits in your brain, okay? So that is the pituitary gland. Why is that important? Why am I pointing this out? There's disorders that you will need to know about in head trauma called syndrome of inappropriate antidiuretic hormone, diabetes insipidus. If this gets severed, then your endocrine system kind of stops working. And one of the places we first notice that is how your kidneys operate and how much you're peeing. So We'll learn more about that, but I just want you to be generally aware. The pituitary gland, you need to think endocrinology, and then you need to think it's very small, and this stalk can be severed, especially in cases of head trauma. All right? Any questions on that? Good. All right. This is straight up on your exam, word for word. It's going to be on your exam. They're going to ask you about the cerebellum, and it's very, very, very important to know this. So, when you think cerebellum, I want you to put cerebellum equals GPS of the body. And you're like, what? GPS? This isn't your sense of direction. This is sense of knowing where my finger is right now in relation to the rest of my body. This is the sense of knowing I have both my feet planted on the ground and my left knee's locked. And all of this information is going back up to your cerebellum to help you stay standing. And it helps with balance and it helps with coordination. Very, very important. And what this is called, it's called proprioception. This is a fancy word that you might see occasionally. And what this is telling you is proprioception is where your fingers are in relation to the rest of your body. You know what's touching you. You know your balance. Okay, it all goes through the cerebellum. Why am I harping on this? Does anyone know something that jacks up our cerebellum that cops test for? Alcohol. If you think of what a standardized field sobriety test is, what are they testing? They're testing your balance. They're testing your finger to nose test because alcohol jacks up your cerebellum. That's why you lose balance. And that's what they're testing for. So you could think, walking a straight line when you don't really know where your right foot is in relation to your left foot, that becomes really difficult if that gets jacked up. Closing your eyes and taking a finger to your nose without visual cues, that takes your GPS having to know where you're at in relation to your body. Does that make sense? Same thing, truncal ataxia. So alcohol actually causes what's called truncal ataxia. Your trunk is what's messed up. It's really not your fingers. But if the trunk, if you're not entirely sure where that is, it's kind of hard to bring your finger up because you don't know where your nose is sitting because it sits on your truncal. So that's kind of my spiel on this is there's disorders that get jacked up, and that is the hallmark sign of the cerebellar injury. Okay, tertiary syphilis, right? Well, that's really the most common. But better example, alcohol is probably a really, really good example. Of course, you can have a stroke in your cerebellum. You can have a stroke anywhere, but think cerebellum is the GPS of the body. And it manages complex motor activity. And we also have some programmed things that go down in our cerebellum. So, I said this last week, but our muscles don't actually have memory, right? Like, that's obvious. But there's parts of our brains that have memory that tie back to our muscle. The cerebellum happens to be one of them. To where if you could play piano or play guitar or shoot a gun really well or drive or whatever, that's all kind of programmed up in there. So when people lose that, they lose the programming of their muscles. That could be a cerebellar insult. So why do I keep talking about the cerebellum? Cerebrum, cerebellum is at the bottom, okay? Students get that wrong all the time, and it's too easy to get wrong, but I will say it's too easy to confuse. They're easy to confuse, but they want you to know the difference, okay? Everybody good with that? Mm-hmm. What they're showing you here is a cross-section of the cerebellum, okay? So all they did was they took this, they did exactly this. They just sliced it open, and this is what the inside looks like, all right? Good. We've touched on all of this. I don't have a whole lot more to add, but they put this in your book, and it's pretty, concise consolidation. So I would say it would not be a waste of your time to know these, to at least be able to know, limbic system, that's emotion, right? You know what I'm saying? Does that make sense? So this is pretty consolidated. It's kind of really is what you need to know. All right. So the brain, of course, it's sensitive to temperature and oxygen and glucose change. So what's the very first sign, Jake, of shock?
Increased heart rate, decrease.
No. Someone help them out. What is the very first sign we will see in shock?
Skin temperature.
No. What? Altered mental status. Thank you. What is the most glucose oxygen dependent organ in the body? The brain. So what's the first one to say, hold up, I'm not getting what I need? It's the brain. It's behind that's the kidneys, but you can't see that as quick. But yeah, it's the brain, okay? So it's going to be, what is shock? Lack of perfusion. The first one to say, I'm not being perfused, is the brain. So don't pick blood pressure and all that weird stuff. That's like the last thing you'll see. It's going to be altered mental status. And the reason behind that is because of how much oxygen and glucose the brain depends on. Right? The brain is literally sending electrical impulses. That takes ATP. How do we create ATP? Oxygen and glucose. Okay? So you have to have those. And as you can imagine, if I were to start choking one of you, you have about 30, 40 seconds before your brain taps out and says, I'm done. You have about 3 minutes until you die. Your brain cells start dying. You know what I'm saying? So that's the reason of like, oh shit, that really is perfusion dependent. Okay? Alright, small alterations can affect its function, right? Temperature, infection, oxygen, glucose, altitude, pick it, right? Very minor alterations can affect it. And it is fairly resilient to internal environmental changes. And that's what I'm talking about. The brain is very soft, but there's a reason your skull is hard. There's a reason we have meninges. It's to protect your brain. Okay? So I don't want to mess with that. So yeah, I would say this: avoid tunnel vision. Right? This is I had to like leave some of this assessment stuff in here because there was stuff I wanted to talk about. So pain response. Right? Pain response can tell us if someone's brain's working because your cell itself is not saying pain, pain, but that pain is being sent up to your brain for you to interpret. This is pain, and I should pull my hand off the hot stove, or I should, stop doing whatever's causing me pain. So of course your brain's used to pain response, but this is what I was talking about: decorticate and decelerate posturing. So decorticate posturing, that's not as bad, right? Decelerate's worse, right? I'm asking for sure.
I believe.
I think decorticate's like bad and decelerate's worse, if I remember right on the GCS scale. The reason for that is the location of the lesion. If it's above the red nucleus in the midbrain, right? Not as bad. When it gets below that, you see decelerate posturing. Has anyone seen this on a real patient?
Once.
It's scary. It's very, very scary. You can even see this sometimes in boxers. When people get knocked out, it's because they just rattle the middle of their brain, right? Their midbrain, and you'll see people kind of posturing up, right? It's because their brain got rattled, right? Specifically at their midbrain. Okay? Now, write these down. It's annoying, I'm sorry. But there are some nerves that I want you to know. There's 12 of these. I need you to know 4 of them. Okay? They are responsible for airway control. Airway, so we gotta know them, okay? But the trigeminal nerve, which happens to be cranial nerve 5, and this is responsible for touch sensation, okay?
Is there something to do with the posturing, like overdosing on different kind of drugs?
Well, hypoxia can cause it too. You know what I'm saying? Because again, if you don't get enough oxygen to your midbrain, then you could start posturing. Does that make sense?
Yeah.
Yep. All right, glossopharyngeal, this is going to be cranial nerve 9, and this is what controls your palate. It's the back of your tongue, okay? So it's the back. Cranial nerve 10, they'll write it cranial nerve X. They usually use Roman numerals, but it's cranial nerve 10, and this has to do with you can know parasympathetic nervous system and also gagging. Those are probably the 2 most important ones.
What is
Gagging, parasympathetic and gagging.
for glossopharyngeal? What's the same exercise?
Palate, it's your palate, it's the back of your throat. It's really your tongue motor. And then the hypoglossal, you might pick up that glossal means tongue, and it's cranial nerve 12, and that's your tongue. The motor of your tongue, like actually moving your tongue, not taste. Okay? This isn't me being fancy, you actually have to know these, at least these 4, because they might pop up. These are all cranial nerves. That's why I wrote, it's just habit now, but it's CN, cranial nerve 9, cranial nerve 5, cranial nerve whatever. Okay? So you actually need to know those. Now, why are these important? Hunter, good question. It's for swallowing. You have to have all of these work in tandem. You have to fill the food back there, cranial nerve 5, to lift up your palate, cranial nerve 9, to allow the gulping reflex to gulp and swallow down, lift your epiglottis, and your tongue thrushes it or throws it back towards your epiglottis or towards your esophagus. So all of these work in tandem to swallow. They also work to vomit. to induce a gag reflex, okay? So all of these work together to allow swallowing and to allow your throat to work. So that's why they want you to know these. Does that make sense? Good stuff? Good? All right, let's go a little bit more and then we'll take a break. But let's keep going. So, if the patient is unresponsive to assist their airway, right, I want to tell you that they throw this word around, and I've defined it for you, but it's trismus. Trismus means clenched teeth, right? So could you imagine intubating someone that's biting down and you can't open their mouth? Very difficult, but no need to fear. There's an antidote to this. We can give them rocuronium, succinylcholine, because guess what? We just took away their skeletal muscle ability to where they can't bite down anymore. Makes sense? Mm-hmm. There's also a condition, maybe if you step on a rusty nail, that can cause trismus. It's coming up in our lecture. Anyone?
It's tetanus.
Tetanus. Good. Yeah, it's coming up. Good. Tetanus causes trismus. It causes people to bite down. We'll talk about that a lot. So anyways, trismus, we also see trismus sometimes in head injuries. Have you ever, again, if someone gets knocked out and they bite down, we also see it in seizures. You ever see a seizure patient bite their tongue and not let go? That's gnarly. I've seen people bite chunks of their tongue off. Right? Cerebral hypoxia, same thing. People can bite down and, what?
Oh, we're going on break.
No, I said we're gonna go on a break. Not yet. Yeah, we'll go on we will,
My bad.
yeah, we'll go after trismus, okay? So give me like 5 minutes.
Okay.
So, trismus, this is what I was talking about. These are kind of old photos, but they're showing you this is tetanus. So trismus is biting down, and a classic vignette they'll give you, I'll talk about this in infectious disease, is a baby with an arched back, because their muscles are all contracting and they can't relax. And it happens to arch a baby's back. And I think this one's hilarious. It's not hilarious, but like I said, medicine has some weird names for stuff. This is called rhesus sardonicus, and it literally means scary monkey face, right? Not my words, but that's a rhesus, the rhesus monkey, sardonicus, means devil-like, okay? So yeah, that's what that means, rhesus sardonicus, and that's what they're showing you here. Okay, so that's where that comes from. Now, if trismus is noted, you have to ask yourself. I say this all the time. Can you ventilate them? No. Can you intubate them? No. Can you crack them? No. You know, you have to know the answers to these questions and be prepared to do each step. Okay, so have y'all been taught how to do nasotracheal intubation?
Yeah.
Yeah.
I showed him a video.
Yeah, it's weird. I've never done it. It's not done commonly anymore. But real important while we're talking about it, the number one contraindication is facial or head trauma. You don't start shoving a tube through someone's nose that has facial or head trauma, right?
You want to intubate the brain?
Yeah, you don't intubate the brain. You missed if you do that, right? But just be aware that that is an option if someone's clenching down and you don't have paralytics. You might be able to shove a tube through their nose and catch it up into their trachea. Does that make sense? So yeah, if you can't, I would go straight to a paralytic or sedative if this were me. But I worked in a system where we had that. So someone asked the other day, could you give a bunch of Versed? Not my taste of medicine, but I will tell you, if you give the patient enough benzodiazepine, they will relax eventually. Okay, so in fact, what causes the problem with tetanus is you're blocking benzodiazepine, right? You're blocking GABA. You inhibit the inhibitor, right? So that's what's happening there. Okay. Any question on trismus? What does trismus mean? AP.
There's like clenching down.
Biting down and you won't let go. Has anyone seen that? No? It's also very spooky because they'll just be biting and they won't let go. If you've never felt metal or metal with teeth, like a laryngoscope on someone's teeth, right? It's nasty. I have seen a patient when I was in EMT school bite down on a laryngoscope, and I still remember that. It was in Graham. So yes.
Can this happen with like somebody in a cardiac arrest too?
Actually, good question. Last class, I had a student, I think it was Waylon maybe, who said that he ran someone that started biting down in cardiac arrest. And the answer is yes, it can. Remember, that would be related to hypoxia. I've actually seen that, where I've had patients start chewing on the eye gel, or the endotracheal tube. So just be generally aware. So if you're doing like I don't know, this is rare, but I've seen this happen 2 or 3 times, where you're doing rock solid compressions, they can get enough cerebral flow, right, enough brain flow to where they can start picking up some function, and they will probably start biting. Okay, this is another reason we sedate patients and paralyze them and stuff like that, to prevent biting. That's a really big thing. One of the main reasons I wouldn't say the only reason, but a main reason we keep patients paralyzed and sedated pre-hospital or in the pre-hospital environment is to keep them from biting at your tube or, eventually just waking up and yanking the tube out. But one of the first warnings of that is they'll start chewing on the tube. They'll start biting on it, okay? So when you are a patient and they start chewing, you better start doing something to fix it, because the next thing is they're going to yank the tube out. Yeah? Good? All right. I'm going to talk about, well, let me just see one thing. Yeah, we're going to talk about this and go on a break, and I'm going to leave this up here if you want to take a picture or not. These are fair friggin' game, okay? They're very, very important. They're annoying, but they're fair game, okay? So let's burn through them really quick, and then we're going to take a break. Euapnea, right? So if someone's euphoric, what does that mean? Good, happy, good. So euapnea, right, means good breathing, okay? So this is a normal pattern. Bradypnea, too slow. Tachypnea, too fast. Hyperpnea, right? So too much breathing, right? Too fast. This can be related to decay. But Kussmaul respirations, okay? The first time you see this, you won't forget it. So if we were to all go, especially after eating taco casa, go running around this building 3 times, first one back graduates paramedic school, right? You're going to come back and you're going to be huffing and puffing, taking deep breaths in and deep breaths out. Why is that? You've built up CO2 and you're trying to get it out. So you can see Kussmaul respirations in exercise. It's common. We've all been there, okay? But you also see Kussmaul respirations in diabetic ketoacidosis. Why is that? They're trying to blow off hydrogen. So they're doing the same thing as if we were to exercise. They're trying to blow off hydrogen. So Kussmaul, remember, it's going to be rapid and deep respirations that are rapid. That's Kussmaul. Ataxic respirations, I want to point out 3 of them because they're all very similar. Ataxic, Biot, and Cheyne-Stokes. Apneutic too. These all mean brainstem lesions. You don't need to know exactly where the lesion's at, just know brainstem. So again, if your body starts pushing on the brainstem, it does not like it, and it will not work the way it was designed, and you will see weird breathing patterns, okay? So ataxic, it's going to be more random compared to like a Biot. These are both irregular, and they're really hard to distinguish. The difference is in Biot's respiration, there's periods of apnea. So if I had to describe Biot, I would say irregular respirations with a period of apnea. Oh my gosh, that's what they wrote on there, okay? So Cheyne-Stokes, you'll see this in patients that, again, they're herniating onto their brainstem. It sounds like this. It's called a crescendo decrescendo with a pause. So it'll be apnea. And that's what they're doing. Little breath, big breath, big breath, big breath, pause. Little breath, big breath, pause. Right? Pushing on the brainstem. Okay? So these are patterns you have to know. And if you see this pattern, this pattern, and this pattern, what is our next step as a paramedic? Yeah, airway control. They are dying. They are on their way out. Okay? They are going to continue to die very, very rapidly. These are ominous. If you see these, it's almost over at that point. Okay, you're pushing on the brainstem that's keeping them alive. Yes.
So even with those respirations, we're going to take their airway, obviously, but that's still pressure being put on that brainstem.
Mm-hmm. Yep. But in this case, the body's not trying to preserve itself per se. It's trying to Okay, I'll give you a quick example, and I know we want to break, but look, Cushing's reflex is the body thinking it's preserving itself. We're going to talk about that after the break. But in Cheyne-Stokes, it's not even trying to preserve itself, it's just pure dysfunction. It's because it's being pushed on. Okay. So it's not like, I'll give you an example. Kussmaul is your body trying to preserve itself. So if you intubate someone in Kussmaul respirations, what do? We match the Kussmaul with our ventilator. Makes sense, right? They have too much hydrogen, so we need to match it. So if their end tidal is 28 when you intubate them, it needs to be 28 after you intubate them because they're trying to preserve themselves. Now, Cheyne-Stokes, Biot, ataxic respirations, not the same, right? This is dysfunction from being pushed on. Does that make sense? Yeah? All right. Now, these other ones, they're pretty self-explanatory, and I don't want to spend a lot of time. The word gives away what they are. But I want to point out, these are fair game, and questions will ride on you knowing what these are. And if you do know what these are, it will give it away the answer. The answer will be right in front of you. Okay? Everybody good at that? All right. Let's come back at 125. And then we'll keep going, all right?